And welcome back to the Curbsiders. I'm Dr Monee Amin with my effervescent friend, co-host, Dr Meredith Trubitt. And on today's video, we're going to discuss acute coronary syndrome for the hospitalist based on a recent episode we did featuring Dr Sanjeev Francis. Where should we start?
We'll start with kind of where we should start, which is with the history. Dr. Francis highlighted that really when you're thinking about chest pain, we should actually really be thinking about chest discomfort to kind of broaden the horizon for who is included in like the ischemic disease picture. And so just highlighting, central pressure like squeezing, gripping, heaviness, tightness, exertional, retrosternal, all of those things should cue you into acute coronary syndrome. But that also when we were all taught in medical school that women present differently or other populations may present differently, that the studies really haven't borne that out. And so whenever you hear any keywords that should clue you into like an ischemic event, acute coronary syndrome, that should hold true to any kind of patient population, and you should go down your appropriate pathways for it.
If you've had the thought, then you need to pursue it, right? In meningitis, if you have the thought that someone needs an LP, do not talk yourself out of it, which is, I think, what his point was here. And I found that to be really pertinent, frankly, and I think really good teaching point.
If you're thinking about other kind of life-threatening events, dissection, PE, then make sure you've, rolled those processes out too, and don't just go down, your other kind of life, limb, body organ threatening condition with ACS and forgetting about your other conditions that could be going on that could present similarly.
For sure. The history wins again. And I think getting a good history is kind of what helps you kind of go down that pathway of determining how high someone's risk is for a cardiac event. We always talk about things like the heart score and sort of the risk assessment phase. For low risk, it's considered a heart score of 0 to 3, and those are patients that can safely be discharged. Then the moderate is 4 to 6, and then greater than 6, there's a very high risk of cardiac event, and those are the ones where you really need to think about invasive measures, i.e. cardiology consult for other procedures. Sometimes you get so bogged down on, is this unstable angina, is this cardiac, non-cardiac, that just slowing down and just assume it's all potentially cardiac and think of how high is their risk.
We always get an array of high heart scores, coming out of the emergency room. And I'm like, it cannot be that all of these people have this as a problem. There's obviously this low risk category that I am never going to see as the hospitalist. And really the question to the hospitalist is your next step for testing.
Right. And once you get to that moderate high risk category, you start doing the workup, right, to kind of further go down which pathway you need to. And I think especially given, what the availability is for some hospitals versus not, the discussion around high sensitivity troponin I found to be particularly helpful.
We mentioned this on the episode that our facility doesn't actually really use high sensitivity troponin, and so it was something that we're kind of less familiar with. The 4th generation tests were really there to risk stratify negative concerns for ischemia versus positive, and that the 5th generation tests, being more sensitive, kind of give us actually 3 categories, and those 3 categories are either normal or they're falling into an abnormal range that's really signifying that there is something else going on that's causing some sort of myocardial damage, or the 3rd category that this is an abnormal troponin really due to myocardial necrosis, likely from some sort of like acute coronary syndrome. This conversation is probably one of the biggest headaches for many hospitalists and is probably, I think, where some of the money is on this episode, talking a little bit about myocardial injury in a little bit more detail. And I thought the other great pearl that Dr. Francis said is when you have these patients, I think a lot of us don't know what to do when they fall into that middle category. Something else is going on. They're here for sepsis, here for whatever other, medical problem. And then you get the positive troponin and what to do. And he was pretty stalwart in that, we should at least be doing some sort of workup for that. And that at a minimum, that should really be getting an echocardiogram on these patients. And if there are other signs or symptoms that may suggest some other underlying coronary disease, that actually should potentially be going further during their inpatient stay to work that up further.
Yeah, and I think he also said that's probably an appropriate time to call your neighborhood friendly cardiologist to help make that determination whether that really is something that needs to be done as an inpatient versus something that could potentially wait after they've fully recovered from their acute issue. And speaking of recovering from the acute issue and potential further workup, I found one of the most helpful things about our conversation was kind of that question we all have is the warranty on further testing, right? So there's so many tests we can do. There's cardiac CT, there's all the different stress tests. But what I think I really appreciated is, yes, technically 2 years for a coronary CT and 1 year for the other tests. However, if the history is suggestive of something cardiac, warranties kind of go out the window, right? Like if they need a further workup, if their story is real convincing, it's convincing. And don't talk yourself out of it, right?
Plaque rupture or thrombus, any of those things can happen at any time. And so really when you're getting the tests, it's only good for the symptomatology that they're explaining to you, I think, at that time. And if something changes down the line, then you still kind of have to take the prior testing with a grain of salt.
He was very clear, right? It was, if it's stone cold normal, absolutely no atherosclerosis, then it should buy you some time. But if there's any disease, you definitely need to think about it if the story's good. Okay, well, we got into much more detail. I mean, it was a banger. It was 2 parts. So click on the link in the transcript if you want to hear the full episode. With all that, I've been Dr. Monee Amin, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And I remain Dr. Meredith Trubitt. Thank you and goodbye.